I have no conflict of interest regarding the content of this presentation, and this paper is published in Annals of Otology, Rhinology and Laryngology in 2017. Nasal mucosa of patients with perennial allergic rhinitis and in majority of patients with chronic rhinosinusitis with nasal polyps in about 90% of patients with nasal polyposis in European population is histologically characterized by intense eosinophilic infiltration, mucus hypersecretion, and airway tissue remodeling. The pathogenesis of perennial allergic rhinitis is well explained by antigen-specific Th2 seals and their cytokines and by release of secretory products, especially eosinophil catechinic protein, major basic protein, eosinophil peroxidase, and other enzymes, and by release of secretory products in the late phase of allergic inflammation. Previous investigations showed increased epithelial cell permeability in primary sinus epithelial cell cultures after the exposure to house dust mite antigens and to Th2 cytokines, especially interleukin-4 and interleukin-13. According to results of previous investigations, the main conditions for nasal polyp growth are chronic inflammation with increased local gene expression for tumor necrosis factor alpha, the presence of bacterial biofilms, infection by Staphylococcus aureus with production of staphylococcal enterotoxins, especially A and B, upregulation of Th2 immune response and downregulation of Th1 immune response, and dysfunction of immune barrier of the nasal mucosa. Eosinophil trafficking in patients with perennial allergic rhinitis and in eosinophilic form of chronic rhinosinusitis with nasal polyps in 90% of patients with nasal polyps in European population is characterized in its development with 4 phases. And phase 1 is recruitment or hemattraction eosinophils. Phase 2 is adhesion and transendothelial migration of eosinophils. Phase 3, activation, and phase 4 is degranulation of eosinophils. The pathogenesis of chronic hypereosinophilia in patients with allergic rhinitis, non-allergic rhinitis with eosinophilia syndrome, and eosinophilic form of chronic rhinosinusitis with nasal polyps is not well investigated. Previous investigations showed increased epithelial cell permeability in primary sinus epithelial cell cultures and increased hemattraction and transendothelial migration of eosinophils driven by chemokines. Eosinophilic chemokines can be divided into selective and non-selective eosinophilic chemokines. Selective eosinophilic chemokines, including eotaxin 1, 2, and 3, attract only eosinophils. On the other hand, non-selective eosinophilic chemokines, including regulated on activation, normal T cell expressed and secreted, or RANTES, monocyte hematocrit protein 1, or MCP1, NCP3, NCP4, and macrophage inflammatory protein 1 alpha, MIP1 alpha, attract not only eosinophils, but also monocytes, macrophages, and lymphocytes. Eotaxin 2, or CCL24, and RANTES, or CCL5, are eosinophilic chemokines with very small molecular masses of only 8 kilodaltons. The primary sources of these chemokines are respiratory epithelial cells, lymphocytes, and macrophages. However, after the process of immunological activation, the main secondary sources of these chemokines become activated eosinophils and fibroblasts. Nasal secretions represent a first-line defense medium in which the leukocytes compartment probably acts as an efficient part of the defense mechanism, along with the mucociliary transport system and the biochemical properties of the mucus. The content of nasal secretions reflect the inflammatory status of the nasal mucosa and evolution of mucosal disease. To characterize inflammatory changes in the nasal mucosa, many secretory products, especially cytokines, chemokines, enzymes, some anti-inflammatory proteins in the nasal secretions may be determined. So the aim of this investigation was to evaluate nasal mucosal production of RANTES and eotaxin 2 and the levels of tissue eosinophilia in patients with perennial allergic rhinitis and in non-allergic and allergic patients with chronic rhinosinusitis with nasal polyps before and after nasal corticosteroid treatment. 60 patients with chronic upper airway inflammation, 20 with perennial allergic rhinitis, 20 non-allergic, and 20 allergic patients with chronic rhinosinusitis with nasal polyps, and 20 subjects with healthy nasal mucosa were included in this combination of one prospective and one cross-sectional study. The diagnosis of perennial allergic rhinitis was done according to ARIA guidelines, and only patients with symptoms for at least 12 weeks of duration and sensitized to perennial allergens were included in this investigation. The patients had confirmation of atopic status, negative nasal endoscopy for nasal polyps, and negative CT scan of paranasal sinuses for mucosal swelling. The diagnosis of chronic rhinosinusitis with nasal polyps was done according to EPOS 2012 criteria, and only the patients with mild to moderate nasal polyposis with a nasal polyp size of 1 and 2 were included. The allergy determination was evaluated in all participants at the start of the study on the basis of clinical symptoms, medical history of allergic rhinitis, positive skin prick tests, and positive serological tests. Exclusion criteria were large bilateral nasal polyps with grades 3 of nasal polyp size, conal polyps, bronchial asthma, non-steroid anti-inflammatory drug exacerbated respiratory disease, systemic diseases affecting the nose, cigarette smoking, previous paranasal sinus surgery, acute upper and lower respiratory tract infections, and treatment by antibiotics, antihistamines, and corticosteroids during the 3 weeks prior to the beginning of the study. All patients with chronic sinonasal inflammation received fluticasone furoate nasal spray in a dose of 220 micrograms per day, with 2 sprays in each nostril in the morning for 14 days to all patients with perennial allergic rhinitis and chronic rhinosinusitis with nasal polyps. We performed the assessment of nasal symptoms, nasal obstruction, hyposmia, rhinorrhea, sneezing, and itching, and we classified symptoms into the following categories: before and after nasal corticosteroid treatment, no symptoms, 1 mild symptoms, 2 moderate symptoms, and 3 severe symptoms, so maximal nasal symptom score is 15. We also performed the assessment of endoscopic findings before and after nasal corticosteroid treatment, and we classified the sizes of nasal polyps before and after fluticasone furoate treatment into the following categories: no symptoms, 1 mild symptoms, moderate symptoms, and 3 severe symptoms. So maximal endoscopic score is 6 bilaterally. We also performed the assessment of findings from CT scans by Lund-Mackay CT score only at the start of the study in patients with nasal polyposis, and the maximum CT score by Lund-Mackay CT score is 24. We also performed the sampling of nasal secretions in all 60 patients before and after nasal corticosteroid administration, and in 20 healthy subjects by so-called absorption technique with cotton wool sticks, which were inserted into the nasal cavity for 5 minutes. After the preparation of nasal secretion samples, we measured the concentrations of rhinitis and eotaxin 2 by commercial ELISA kits. Nasal eosinophil counts were performed before and after corticosteroid treatment of nasal scrape tissue obtained from the ferriturbinate bilateral bioretinal probe, and the eosinophil counts were expressed as a percentage of cells of the granulocyte and monocyte origin without the nasal epithelial cells. In our results, we found significantly higher nasal symptom score in allergic patients with nasal polyposis than in non-allergic nasal polyp patients and patients with perennial allergic rhinitis. We found no significant differences in the endoscopic score and CT score between non-allergic and allergic patients with chronic rhinosinusitis with nasal polyps. We found significantly higher total serum IgE levels in allergic patients with nasal polyposis and patients with perennial allergic rhinitis than in non-allergic nasal polyp patients and subjects with healthy nasal mucosa. And finally, we found significantly higher eosinophil counts in the nasal mucosa of patients with allergic patients with nasal polyposis than in non-allergic nasal polyp patients and patients with perennial allergic rhinitis, and especially than in the subjects with healthy nasal mucosa or controls. Before the start of nasal corticosteroid treatment, we found significantly higher concentrations of rhinitis and eotaxin 2 in the nasal secretion samples of patients with perennial allergic rhinitis and non-allergic and allergic patients with nasal polyps than in the subjects with healthy nasal mucosa. However, we found no significant differences in the local concentrations of these chemokines between patients with nasal polyposis and allergic rhinitis. After the 14 days of fluticasone furoate administration, we found significantly decreased concentrations of rhinitis and eotaxin 2 in the nasal secretion samples of patients with perennial allergic rhinitis and non-allergic and allergic patients with nasal polyposis. After the therapy with corticosteroids, the number of eosinophils in nasal mucosa and nasal symptom score were significantly decreased in all three groups of patients, and the endoscopic score was significantly decreased in both non-allergic and allergic patients with nasal polyposis. And finally, in conclusions, we found no significant difference in rhinitis and eotaxin 2 production by nasal mucosa among the patients with perennial allergic rhinitis and non-allergic and allergic patients with nasal polyposis. Nasal fluticasone furoate treatment reduced sinonasal symptoms, eosinophil counts, rhinitis, and eotaxin 2 production in all patients with chronic sinonasal inflammation. The measurement of rhinitis and eotaxin 2 in nasal secretions could be reliable for assessing the treatment outcome during corticosteroid treatment. Thank you very much.
Thank you for a very nice presentation. Do we have some questions or some comments, Professor Kalogera? I just want to say that there must be, there was a little mistake. You said twice in the morning and 220 micrograms. That is 2 times 2. So it was probably just a mistake on the slide. Was it 2 times 2?
2 times in each nostril in the morning.
Just in the morning?
Yes.
That's
just in the morning.
110, okay.
Because we have patients with chronic sinonasal inflammation.
Okay.
Thank you for the presentation. I'm interested in this Lund-Mackay score in controls and perennial rhinitis. Is it not done or is it really zero?
No. For patients with perennial allergic rhinitis, we not performed.
Yeah, because it's zero, but it's not done.
Chronic
it's
rhinosinusitis.
not done. Okay.